All right. Chapter 24, forearm, wrist, hand, and fingers. Some of this stuff was already talked about in the elbow, so I'm going to graze over those things and then just kind of bump into the things that we haven't discussed yet. Forearm stuff, already talked about it, all the bones, interosseous membrane that runs down. We discussed that the radius is smaller proximally, ulna is bigger distally, the radius is bigger, and the ulna is smaller. The things to look for, styloid processes on both of them. These are major attachment sites. And then as we look at them, I would say they're really kind of difficult to tell down at the wrist, which one's anterior and posterior. I would really use the proximal aspects of these two bones to determine what it is you're doing. Just because we're not going to go over them enough for them to really make sense to you. On the proximal side, one thing, notice that this is kind of more flayed out at you or kind of fanned out, and the extensor side or posterior side is more rounded in, because we're going to be coming forward into flexion and then extension. Those bones are going to round over the top of it. For the muscles, we've already talked a lot about these. When we see pronator, it's going to be a muscle that helps us pronate. Supinator is going to help us supinate. The supinators are on the posterior side. The pronators are going to be on the anterior side. We talked about the various types of muscles as they come down. We do have, what else? Oh, so a couple things to look at. We have our flexor digitorum superficialis, and where's the other one? Oh, I don't see it. Okay. When we get to the muscles for the injuries, we're going to talk about this. But for these, there's going to be two different ones. So notice this guy, the superficialis, only inserts here on the middle phalanx. Okay. Only here on the middle phalanx. And then when we look up here, oh, they don't have the muscle listed. Okay. Oh, sorry, they do. Flexor digitorum profundus. So notice superficialis profundus. Superficialis means more superficial, right? And if it's a flexor, it's going to be on this flexor pronator mass. Over here, then we have the flexor digitorum profundus. And with this guy, they both come down all four digits 2 through 5, sorry. But notice that the profundus comes all the way to our distal phalanx on these fingers, okay? So superficialis comes to the middle phalanx, and the profundus comes all the way down to the distal. And this is going to be really important when we talk about big finger injuries, guys and girls and people and everybody else. So make sure that we're paying attention to that. Superficialis ends here, profundus ends at the very end, okay, on our distal aspect. Okay. Forearm fractures, jumping right in. When we talk about these, and we talked mostly about humeral fractures previously. Understanding forearm with these, we're usually looking at a direct blow or a fouche. If the ulna and radius are fractured, and typically we're looking at, usually the radius is the one that's fractured, we're looking at a Colles fracture, and it's going to be this kind of nice movement of the bones, and we'll talk about them in just a second. And we also have a reverse Colles fracture, and I'll show you these. Pardon me, this is an open version. So that's his elbow like this. He's bent like this, and then he's bent backwards, kind of like my hand right there. That's not how your arm's supposed to look, by the way. We can also get Volkmann's contractures down here because, again, all those vessels and nerves that we talked about through the elbow also come down. So we need to be really careful. Often it's pretty obvious when you break your forearm, and severe pain, disability, swelling, ecchymosis is discoloration, right? And crepitus, where the grinding kind of stuff. Management is going to be our police right away. Splinting, make sure we do our PMS before and after, and then long-term casting. Occasionally, though, they'll have to go to surgery. So as you look at this, you should be able to tell which bone this is, if it's the ulnar or the radius. Remember, the radius is always lateral. And also it's smaller at the top. You can see that radial head right there. So this is an ulnar, sorry. Oh goodness gracious me, oh my. This is an ulnar fracture, not oh, you couldn't see what I was doing. Sorry, this is an ulnar fracture, not a radial fracture, because again, you can see the head moving right there. Okay. Ooh, I went too many. A Colles fracture, this is something you guys need to understand. So it's in the lower end of your radius. This is what we're going to be talking about. And it's a foosh forcing the radius and the ulna into hyperextension. So you're falling like this. Less commonly, you're going to see the reverse Colles. So notice the difference in how these are set when you're looking at the two of these. And obviously the ends of your bones don't look really nice like this at the wrist. But if you look at how these two are situated, what you're seeing is these guys are dropping off, and notice how this part is coming through. So when they're doing a Colles fracture, they're landing like this, versus a reverse Colles fracture, they're landing on the backs of their hands. This does not happen very much. When that happens, you're going to see the distal aspect move more posteriorly. When we fall like this, we're going to see more of an anterior kind of motion of the bone moving. Okay. And this is just kind of what it looks like. So see that really nice drop off. This is called a silver fork or silver spoon kind of injury. And they can be quite painful. By the way, this is an athletic trainer. All right. So wrist and forearm, there is so many bones. I need you guys to know the carpal bones. And I gave you kind of some help. So scaphoid lunate, triquetrum pisiform, trapezius or trapezium, trapezoid capitate hamate. Some lovers try positions that they can't handle. I learned this when I was in undergrad. It stuck with me. I remembered it. There's a couple other things that you guys can learn that way too. If you don't like it, there's lots of others that are posted. And actually you can even look in your supplemental materials and find them there. The way to remember the T's, triquetrum doesn't look anything like the other one. So it goes in the proximal row. And then trapezius and trapezoid, they're in alphabetical order. So starting, I always look at them from the posterior side of the wrist. You're going to start in this thing right here. Can you guys all see that hole? Turn my arm. Sorry. It's really hard to do. Oh, there, that's good. If you extend your thumb out and kind of lean in, you can see these tendons. That hole right there is called your anatomical snuff box. Learn that, because inside that hole is where your scaphoid sits. Okay. And we're going to talk about this in a little bit. Inside there, that is where you're going to start. Proximal, lateral is your scaphoid. Then you have your lunate. Okay. Then you have your triquetrum. And on the anterior side, you have your pisiform, because otherwise you can go scaphoid, lunate, triquetrum, pisiform. And pisiform is this little bitty ball thing. You should be able to feel it. It feels like a P up right here. And this is called your hypothenar eminence. This is your thenar eminence. Hypothenar eminence, meaning kind of all the muscle by your pinky. Thenar eminence are your brevises, your muscles for your thumb. Okay. Also known as your pollicis, right? So your lunate sits right in the middle, and your median nerve runs just superficial to that lunate. And that's easy to remember because your lunate is your number one dislocated carpal. And it happens when you fall in a foosh, just like this. And sometimes it sticks out and it'll look like carpal tunnel because your median nerve is getting smashed by the dislocated lunate. So scaphoid, lunate, triquetrum, pisiform. Then in the distal row, you have trapezius or trapezium, trapezoid, capitate, and then your hamate is up here again. And if you find your pisiform and you come distal and medial and you push in here, you should be able to feel this weird like bony hook thing. That is the hook of your hamate. Okay. We'll talk more about that in a little bit. So I went too far. We have several joints in this area, and in general, our radiocarpal joint does flexion, extension, abduction, adduction. So those are from anatomical position. You can't see me. So abduction is going away, adduction is going towards, But the way that I want you to think about them instead, abduction is also called radial deviation because you're moving towards the radius. And then ulnar deviation is adduction because you're moving towards the ulna. So radial deviation, ulnar deviation, radial deviation, ulnar deviation. And then circumduction is making circles. We're not quite as good as circumducting our wrists as we are our thumb because we have a saddle joint in here and our shoulder and hips, but we're pretty good at making circles. We can make it happen. The ulnar carpal joint is separated by our TFCC, triangular fiber cartilage. So ulna over here, remember, it comes in and you have this meniscus really that's similar to what you have in your knee. So it's cartilage and then a whole bunch of ligaments that hold it together. And so you can kind of mess that up. And when we hurt that, it's a lot of times from a foosh, and it can cause a lot of pain and instability in our wrist. The disto-radial ulnar joint does pronation, supination, like we talked about before. And then our intercarpal joints, these dudes that sit in the middle, they can move, but not so much. And when we do stuff, we just kind of like move them around with our hands. You need to know this picture. You need to know this picture. You need to know this picture. Are you on the anterior or posterior side? This is something that you need to be able to figure out by looking at the picture. What are the things that you can only see anteriorly? There's two things that you guys should be able to pick up on based upon what I said to you earlier. The first one is that you can only see the pisiform on the anterior side. The second one is you can only see the hook of the hamate on the anterior side. So if you can see this guy and you can see this guy, you have to be on the anterior aspect of the hand. Notice that the scaphoid is far more proximal than most people think it is. Most people think that this is a scaphoid. The scaphoid is a really big bone, and it is more in line with your second than it is with your first. Now your first, I mean, notice if you do this angle line, absolutely. But if you're going to go just straight down, it's really, if you're coming straight down, it's really in line with your second, not your first. So just remember, you dig in here, which is your anatomical snuff box, and that's where your scaphoid is going to be. So scaphoid lunates, remember lunates in the middle. And then we have our triquetrum, which is kind of hard to see and palpate from the anterior side. It's much more visible from the posterior side. And then the pisiform, that little bitty P guy. Then when we come back over, we have our trapezium, our trapezoid. Then we have this really big capitate. Notice it is just south of that third metacarpal. And then we have our hamate that is kind of in between our fourth and fifth metacarpals, with the hook being just, so you found that pisiform being just north of that, and you should be able to feel that little dude that sits in the palm of your hand, okay? Well, very proximal part of your hand. But you need to be able to find this. These are all your metacarpals, 1, 2, 3, 4, 5. First is always your thumb, just like it was in your foot. And again, don't get confused. Some of these images make the proximal phalanx look just like the metacarpals, like same length, same everything. Your metacarpals attach to your carpals. Your phalanges or phalanxes either are next to one another, or here at the MCP joint, the metacarpal phalangeal joint. Again, we only have one interphalangeal joint here in the thumb, this guy, but the rest of them have two, being the proximal and the distal interphalangeal joint. And remember, this is not the joint. This space right here, when you pull it out, that sits, hopefully you guys can see how it divots in right there. Oh, can I make it happen better in another finger? There. Oh, you can see it good there. You see how that divots in right there? That space is the joint, not this. This is the head of my metacarpal. The joint where it divots in, that is the space. That is your joint, okay? So then when we think about the hand, again, we can see this pisiform, so that means we're on the anterior side. We have, remember I said at the elbow, we have an ulnar collateral ligament down here in our wrist. So ulnar collateral, radial collateral ligament on both sides. And then we have that transverse carpal ligament, which is what helps make up the ceiling of our carpal tunnel. We also have the canal or tunnel of Guion that runs just medial to, well, technically lateral to, but closer to the middle of your hand from the pisiform, and that is where your ulnar nerve rides. And the way that you can maybe remember that is people that ride bicycles a lot, they put a ton of pressure there, and they used to have very different handlebars. They changed the handlebars and started putting like aero bars and stuff because competitive riders were basically having permanent damage to these two fingers because they were putting so much pressure on their ulnar nerve. And if you guys have ever done enough stuff where you've been putting pressure on your hands like that, you know that that can be a major problem, and nobody wants permanent damage in their hands. Okay, remember before I was talking about the superficial and the deep, also known as the profundus tendons, the flexor tendons. Remember, superficial comes in inserts on the middle. Notice it kind of splays and comes back together because this deep tendon, also known as a profundus, the flexor digitorum profundus, comes all the way, it goes between these two, all the way to the distal. And again, this is going to be important when we talk about a couple of the hand injuries, the finger injuries. And then we have this one, we don't have two flexor, we have two flexors, we only have one extensor, this one extensor digitorum tendon. Okay, so make sure we can keep these separate in our brain because it's going to be important. Okay, we're just going to roll through and do all of this at once. Boxer's fractures. If you don't know how to punch, you're going to hit with the outside of your hand and you're going to break it and it's going to hurt and you're not going to like it. Pain, crepitus, when they make a fist, you're going to have a depressed or absent knuckle. Major issues with grip strength. You need to send them for x-rays, immobilize, and potentially surgery. Notice this is the head of his metacarpal. This is the shaft of his metacarpal. This fist looks good. This fist is missing 1 to 2 knuckles. And this is how they should really be immobilized, is in this position. So that way it's pulling the bone straight. And people don't always have to go get x-rays, or not x-rays, sorry, surgery for this. But depending upon how these two things are lined up, it might be necessary just because the physicians might not be able to line them up in any other way, which can be a major problem, right? Like you need to make sure that you can get all of that stuff taken care of and that it is appropriately lined up. Metacarpal fractures, meaning these dudes through the middle. This was one of my offensive linemen who decided to break his fourth. It's totally possible to also break bones other than your fifth. But again, you would look for discoloration. He had a ton of swelling through the palmar as well as the dorsal aspect of his hand. Buddy taping works really good if they're lined up. If they're not, we're going to have to do something different. But for him, buddy taping was enough because it wasn't displaced. And so he was able to play mostly. And we had to do some padding and he had like we put a cast kind of thing on him. It wasn't a cast. It was a orthoplast splint that he wore. And then we wrapped in a whole bunch of bubble wrap and he did actually pretty well. Wrist sprains. Most common wrist injury is to sprain our wrist, abnormal weird force motion. So hyperextension, like falling on a foosh, flexion, some kind of torsion stuff. If it happens over and over, we can start messing up the blood supply, but in general, we're going to take care of it like a regular sprain. Carpal tunnel is a chronic injury. And remember, I said the median nerve runs through here. So it happens a lot when we're typing and using bad form. This used to be considered a secretary injury. It is no longer considered that because everybody types all the time and play video games and doing all that kind of stuff. So what happens is you impinge upon the nerve and potentially the vessels and everything else. You can also get repeated direct trauma to the anterior wrist, or even sometimes just a really bad one that causes massive swelling. But they're going to start to get like issues with grip strength, problems the longer that they stay in a flex position, paresia or tingling going down to their hands. Usually they put you in a cock-up splint that kind of keeps your wrist straight for a period of time. And if that doesn't work, they maybe do injections. And if that doesn't work, they go in and they actually cut the retinaculum that goes across, which is not usually what you want them to do because it changes the entire structure. Like we said, if you tear your plantar fascia, it changes the whole structure of your foot. Same thing. lunate. Remember I said it's the most commonly dislocated bone in your wrist. It goes anterior from a fouche. We fall like this and all the bones push forward. And so it comes out and it impinges on our median nerve, which is why it can mimic carpal tunnel, the thing that we just talked about. Pain, swelling, discoloration, paresia. A lot of it's going to mimic what we have again for carpal tunnel, but the difference is going to be they don't have a mechanism for carpal tunnel, just kind of got worse and worse and worse, but they do have a mechanism. They fell, they probably felt something like a pop or they heard something ugly in their wrist, and then it immediately hurt. And they may or may not have like a bump here, but probably they kind of do. You need to treat as an acute injury and refer for reduction. Do not pop that bad boy back in yourself. If you can't tell that it's dislocated, for sure, I would still refer for x-rays, because if it doesn't get put back in, it can actually degenerate some, which then would require you to actually send them for surgery to have the bone removed, which again is going to change the structure of their wrist and hand. Don't do that. It can take a couple months to come back from it. Scaphoid, also called the navicular, which is a bone in your foot. I'm going to tell you right now, I'm just telling you these two names are synonymous because it's going to help you when we're talking about like just general medical terms. I will never in any quiz or exam or assignment or anything use navicular when I'm talking about this bone, because I think it's too confusing. In this class, I will always call this bone your scaphoid. Okay, always. Fouche, most common mechanism by far and away, because the scaphoid gets slammed between the radius and the second row of carpal bones, which that first one is your trapezium. Okay, the problem is it usually breaks in the middle. One side has good blood supply, the other side doesn't. So we get what we call the dreaded black line, also known as a non-union fracture. So people typically have to go to surgery. Here's an image of that snuff box I was talking about, and pain with radial flexion, also known as radial deviation. Grip strength is probably going to get messed up, and general range of motion is going to be messed up. Refer for x-rays. They have to be immobilized for at least 6 weeks. For athletes, we often take them to surgery. It's not absolutely like necessary that it has to happen, but usually it happens. And so what I want you guys to see is in this picture, what it is that we're looking at. So number one, can you identify the scaphoid? Where is the scaphoid? And then can you see the fracture? Maybe. My thing's frozen. Oh no, I went too far. There we go. Scaphoid is over here. Remember, we said that it's a bigger bone, but it's also not right next to our thumb. It's down here, basically straight in line with our second. And this is our fracture site. Okay, this is our fracture site as we're looking at this kind of stuff. Half of it gets blood, the other half doesn't. If we don't have surgery a lot of times, this side can actually die. I had a baseball player that had that happen. He was amazing. He still was an all-American outfielder and could barely bend his wrist at all. He actually played baseball, played left field with the cast on, and still threw people out at home. That's how good he was. And he couldn't flex his wrist while his cast was on. Yeah. Anyway, also I'd like to point out that he broke it when he was in high school playing quarterback, not while he was my athlete. Just throwing that out there for you too. Hamate fractures, baseball, softball, mostly baseball though. I saw one guy when I was at Penn State. When I was a grad student working with them, he swung and the vibration. So the bat, if you know, rides right through here, right? A lot of men and women that play get calluses from the bats and the vibration of them. And so they came through and he swung and he got jammed and it broke off in his right hand. And we were like, oh crap. So we went in, did the surgery, took out the fractured hook of the hamate. He came through, he did all of his recovery stuff. He's like, sweet, there's still some of the season left. Very first at bat after that, takes a swing, gets jammed, breaks the other one off. End of senior season. Sad face. So that right there is the hook of your hamate. The reason why it's so important is because this is one of the attachment sites for the retinaculum that goes across your carpal tunnel, that makes your carpal tunnel. So kind of a bad deal. Non-unions, fairly common because of the muscular attachments that go there, as well as that retinaculum. You can protect with a donut pad, you can do all kinds of stuff, but it's kind of one of those injuries that just sucks. Okay, trigger finger or trigger thumb. This actually doesn't usually happen to your trigger finger. It happens to your other fingers, usually your third and fourth or your thumb. Repeated motion of the fingers can cause irritation, causing a tenosynovitis, and then it thickens, and then it forms a nodule that can't slide through. So you can see how this is thickened right here, and then you have a retinaculum that it's supposed to be able to go back and up through, and it can't. And so what you're going to get like is a palpable swelling that goes through there, and maybe like a pop, an audible pop, sometimes even very painful, and it's going to get stuck in position. This actually happened to me, and I'm going to show you a couple pictures of it, and it happened in my thumb. And so injection splinting can be your last options if doing stuff doesn't help, and I ended up having to get that done. And so you can see which of my fingers doesn't look like it moves like the other. Remember, I said it's reduced motion, not increased motion. So the one with fingernail polish on it, you're lucky that I help you guys out with this stuff. Notice how much it can extend and go all the way back. This other guy is way fatter. It's way more swollen, and I can't extend it. It was stuck. Now I've had my injections and I can make this happen, but it didn't do this in the beginning. So it would get stuck here, and my thumb kept getting pulled more and more down. And it's because as a therapist, I use my thumbs a lot. I did tons of massages and trigger points and all kinds of things. And so I've overused my thumbs. And so I have problems with my thumb, which sucks. This video is actually
most people
of me getting my injection. So that's numbing, like a superficial numbing lidocaine. Notice it's turning.
Makes it very cold.
Yeah.
Now we're mixing a little bit of steroid with lidocaine. This way.
Go right into my joint. And now it's in the joint. And out. And that's my video.
Speedy.
All right.
Hey, have someone feeling this? Most people just want to forget.
Yeah.
Okay, so this is
for some reason I had it twice, just in case if you guys didn't get it the second time. So anyway, yeah, that's on there. And it felt, actually I could almost move it immediately, although it took some time for the medicine, to the corticosteroid, to help reduce the inflammation. So I could finally go back, and it took me quite a while to get back to this again. I've had to have that injection done a couple times, but it made a huge difference. Gamekeeper's thumb is another thumb injury that I think is really important for you guys to hear about and understand. It's a sprain of the UCL. Remember, I said that there is another UCL in the body. So we have one here, we have one here, and we have one here in the thumb. And what happens is it's here between the MCP joint of the thumb. So remember, the thumb gets weird. It's right here where our first metacarpal meets up with our proximal phalanx, and it sits right here. Don't look for it down here. Don't look for it up here. It's right here in kind of the web space. Most common is forced abduction and hyperextension. So think about if you're skiing, skiers get this a lot. So if you fall with a ski right here, or while you're holding something and you fall, what happens is your thumb gets taken out to the side. By the way, it looks like I have a gamekeeper's thumb, but I don't. I'm just hyper flexible. So both of my thumbs do that. So, but it looks like it because you can see how that joint opens. It shouldn't actually open like that, by the way, but it's abduction and hyperextension of the thumb. Super common in skiers and football linemen because they get their thumbs stuck on the pads of the other players. And sometimes in baseball and softball, when they're sliding and they'll catch it like on the ground or on a base, they're going to have pain over the UCL and a weak, painful grip strength, and their ability to like squeeze isn't going to be nearly as good. You're going to do a valgus stress test like I just did, and you're going to compare right to left to see if there's greater laxity or movement of the joint. And if it's unstable, make sure you refer for x-rays and potentially an MRI. We can splint it to see if it fixes it. I have had to take some people for surgery before, but usually splinting will work well, but it can take 3 weeks and sometimes more because it's a ligament. And then usually when they come back, we still have to do like casting or splinting or something like that for them to be able to play. A Bennett's fracture is very similar to a gamekeeper's thumb, similar mechanism and all that kind of stuff. We can also get it through a direct blow, like coming straight down through the thumb. But typically it's not like this. It's more like this when it gets hit. Okay. And or a fall onto it, like biking as we go over. So it's a fracture dislocation typically of the carpal metacarpal joint. So instead of being this joint, we're doing it more down here. And so what's happening is we're getting this fracture down here. And I'm going to show you a picture of a much bigger one in a second. But this is the most common of the thumb fractures that we see as a Bennett fracture. But crepitus, you can potentially have a depressed knuckle, like this doesn't stick up the same as this one does as we go like that. They can't make a fist because it's unstable down here and it hurts. And then grip strength is going to be all messed up. X-ray, price, or police, and then they're going to have to be immobilized. And most likely they're going to have to get ORIF, open reduction internal fixation. By the way, this is a huge Bennett's fracture. Notice this is the most proximal aspect of their first metacarpal, and it should be in a line with this way down here. Like this should be here. This should be here. It's off by like a solid inch. This one is going to surgery, folks. Mallet finger is another finger injury that we see really commonly. And what happens is you take a ball, this happens a lot in basketball and in football actually, where you take a ball right off the tip of the finger and then you tear your extensor tendon. So your finger gets stuck like this and you can't bring it back up. I can passively push it up and I can actively flex it, but I can't actively extend it. So it gets stuck just like this. And it can be an avulsion fracture or an actual tear of the tendon itself. Pain in your DIP joint, okay, unable to extend it and point tenderness. You are going to have to splint this thing for 6 to 8 weeks and you can't take it off. As soon as you take it off and the finger goes back down, your 6 to 8 weeks starts over. I had a couple rugby guys that didn't believe me and they ended up being in the splint for months and months and months because they kept taking it off. But this is what it looks like. You can tear that or you can get an avulsion fracture. Any of these are all considered mallet finger because now they can no longer still extend that tendon. Okay, so then we also have a boutonniere deformity. And this happens, and remember before I said that we were talking about injuries and what's happening with them and understanding where they are. So with these, again, this is going to be an extensor tendon, not a flexor tendon. But what we're going to see is as that extensor tendon comes over a middle phalanx, that it's going to tear and it's going to drop down in the sides. And so we're going to be able to move our DIP just fine, but our PIP is going to get stuck in flexion, just like this. And what we're going to do is we're going to put them in a brace that's going to hold them straight at their PIP and then encourage them to still move their DIP. So again, they can't extend the PIP, but they can move the DIP just fine. And again, we're going to have to splint them for 5 to 8 weeks while it heals. So this is what the tear looks like. They get stuck in this position, but the brace, look at how easy and simple this brace is. You're just holding them straight. It doesn't have to be crazy. It just has to work. Jersey finger. This is one that we don't like because it is horrible to fix. It is a rupture of the flexor digitorum profundus. So remember I said this is the one that goes all the way to the end. So what happens is you rip it off. And jersey finger, weird, it's because you're holding on a jersey and they pull it out. So it pulls your finger that was flexed into an extended position really fast. So your DIP gets ripped into extension. And what happens is it pulls off the flexor digitorum profundus tendon, either an avulsion or tears the tendon itself, and makes it so now when you make a fist, it looks like this. Notice all of these are good. This guy is hanging down because I can't actively flex this anymore. It's going to be stuck. This guy, to fix it will require surgery. But most people don't do surgery for this because the rehabilitation is horrible. The surgery is horrible. So unless you're going to try to be a concert pianist or a cellist or something like that, they're not going to mess with it because it's going to take so much time and effort and money and pain, and the outcomes aren't necessarily all that good. It's often not worth your time and effort to try to do it. So they're going to ask you, if you get this, what are your goals in life? And if they don't require really fine motor movement of your hands, they're going to be like, yep, you're just going to have that. And this is what it looks like. So kind of extended, notice they're not able to flex that DIP. And it's usually from this, you get your finger stuck in there and then you rip off that flexor digitorum profundus. Here are some fractures of your, well, actually one of my athletes' fractures of their proximal phalanx. Notice you can actually see more than one fracture in here. There's a chunk of bone in the middle and one here. Here it kind of doesn't look that way, but again, you can see it fairly good here. This person was twisted, and so they had soft tissue that was actually stuck inside in between these fracture sites as well. And so they had to go in and do a surgery to pull this stuff out. So it technically has 3 pieces. So this would be a comminuted oblique fracture. It's oblique because it's angled, okay? And comminuted because it has 3 or more pieces. If it didn't have this middle part, it would just be a regular oblique fracture, but because it has 1, 2, 3 pieces, that makes it a comminuted fracture. When we talk about this, this is a displaced 4th oblique. So do you see this right here where we kind of have this angling going on? Same here. The finger is like sliding off a little bit, which is kind of awkward as that happens and not something that we're really trying to have happen to many of our people. So these boxes hopefully make it a little bit easier to find it. For this individual, they end up having to go in for surgery. As did this person who had to have their proximal phalanx. Again, they had an interarticular fracture, so it actually ran through the joint, and they had to hold these pieces back together to make sure that it worked again. What's the most likely diagnosis of this? And I want you to look at it and really look at it. What can you see? What makes the most sense? Where is it located? So number 1, where is it located? Hopefully you got the DIP, the second DIP, right? Because it's right here, okay? What do you think this is? This is articular cartilage, meaning that this is an open dislocation of the DIP joint. Because that's the cartilage, that's what it looks like. So that's an open dislocation. They didn't break it. They have a dislocation of this joint. This was one of my football players. All right. Which one of these is mallet finger? B. The most common mechanism for gamekeeper's thumb is abduction and extension. When we're like this, right? When we're pulling it down, that's my finger on a femur, by the way. You're welcome. Okay. So sprains of these, kind of like we talked about in the toes, we can do all kinds of stuff, but basically we're going to buddy tape them together. You need to buddy tape them to the longer finger. So if I hurt this guy, I would need to buddy tape it to this. If I hurt this guy, I need to buddy tape it. I don't know if you can see. If I hurt this guy, buddy tape it here, because if I hurt my DIP, my pinky isn't long enough. It's not going to get there. So I need to buddy tape it to a finger that's going to be safe and longer than it. But they're a sprain. People aren't going to die from them. Yeah, you just kind of need to take care of it. Varus and valgus glide and slide tests are what you're going to do to look at those IP joints and really test them. And again, you can do it in anterior posterior glides or varus valgus. From a rehab standpoint, there are so many squeezy things out there in the world. These are called T-band webs or TheraBand webs. There's balls, there's squeezing things, like all kinds of stuff that you can use to work on this kinds of stuff to get their hand grip strength. But a lot of it is coming in, right? You can also use the webs to push out, to twist, to do all of that kind of stuff. Because don't forget, you have to work extension as much as flexion. There is ways to tape fingers, so buddy taping, and lots of braces out there. It just depends upon what you're trying to do and what you're trying to prevent. Be prepared. Do not wear rings to play sports. This came off because they were wearing their ring playing basketball and caught it on the mesh for the hoop. I've also seen people catch rings on the actual rim itself. I myself actually almost degloved myself because for whatever reason I forgot, and I wore my rings in the weight room and I caught it on one of the racks and I felt my ring like dig into my finger and start tearing stuff off. It wasn't awesome. I wasn't excited about it. It hurt a lot. If you're going to work on engines, if you're going to work with things with motors, like whatever it is you're doing, do not wear rings. It is a terrible idea. This is called a degloving injury, meaning that you take off like a glove, you take the glove off and the fingers come off. This person took off all the meat, all the everything. These are the bones and the ligaments. That's what's left. Also took off from the DIP down. So they are missing their distal phalanx. Yep. No, it's terrible. Okay. So same stuff as the other one. Read your stuff, understand the anatomy, the mechanisms, learn how the mechanisms are different, because the mechanisms are really going to help you guys with this stuff. If you have any questions, let me know. And otherwise, I'll see you soon.